Hello everyone. In this class, we'll discuss about some of the extrapyramidal tracts. First, rubrospinal tract. Rubrospinal tract originates from red nucleus located in the midbrain. Red nucleus receives strong excitatory input from motor cortex and cerebellum. We see its course immediately after originating from the red nucleus, fibers cross over to the opposite side at the same level. Note that both lateral descending system, that is lateral corticospinal tract and rubrospinal tract, cross over to the opposite side. After descending down through contralateral brainstem, fibers occupy the lateral column of the spinal cord. The fibers terminate on the lateral group of motor neurons that innervate distal limb muscles. Rubrospinal tract excites flexor group of muscles and inhibits extensor muscles. The important function of rubrospinal tract is to control skilled voluntary movements. In experimental animal, the lesion of the rubrospinal tract produces deficit in the distal limb muscles, especially in the flexor group of muscles. However, if the lateral corticospinal tract is intact, the deficit persists temporarily. Coming to the median system pathways, it is vestibulospinal tract. Vestibulospinal tract originates from vestibular nuclei. There are 4 vestibular nuclei: lateral, medial, superior, and inferior. The vestibular nuclei receives input from otolith organs and semicircular canals. Therefore, the vestibulospinal tract maintains body posture in response to change in the head position and acceleration of the body. Vestibular nuclei are also connected reciprocally with superior colliculi, cerebellum, reticular formation. Therefore, they also control eye position during head movement and balance of the body during the movement. There are 2 important vestibulospinal tract: lateral vestibulospinal tract and medial vestibulospinal tract. The lateral vestibulospinal tract, it originates from the lateral vestibular nuclei, that is diatus nucleus in the brainstem. If you see its course, this tract descends down ipsilaterally through the brainstem and spinal cord. The fibers occupy the ventral funiculus of the spinal cord and terminate on the medial group of interneurons and motor neurons in the ventral horn of the spinal cord. This tract extends throughout the rostrocaudal extent of the spinal cord. If you see its function, it excites the motor neuron that supply proximal group of muscles, especially the extensor muscles of the limb, and thus lateral vestibulospinal tract controls posture. The input to the lateral vestibular nucleus comes mainly from the semicircular canals and otolith organs of the inner ear. Therefore, lateral vestibulospinal tract controls the body posture in relation to angular and linear acceleration of the head. In decerebrate animal following midcollicular section, the lateral vestibulospinal tract becomes hyperactive due to the loss of inhibitory control from the cortical areas on it. Therefore, extensor rigidity is hallmark of decerebrate rigidity or in decerebrate animals. In humans, brainstem lesion due to stroke or injury facilitates the vestibulospinal tract activity that manifests in the form of neck, arm, and leg rigidity. Medial vestibulospinal tract originates from the medial vestibular nucleus. See its course, it descends down ipsilaterally in the brainstem and ventral funiculus of the spinal cord. It extends up to the mid-thoracic spinal cord segments. The fibers from medial vestibulospinal tract terminate on the medial group of interneurons and motor neurons. The function of medial vestibular spinal tract that they controls the body posture. The input to the medial vestibular nucleus comes mainly from the semicircular canals. Therefore, the medial vestibulospinal tract adjusts body posture, especially the head position, in response to angular acceleration. Coming to reticulospinal tract, the core of brainstem contains reticular formation. Reticular formation receives input from the spinal cord, vestibular nuclei, cerebellum, hypothalamus, tectum, and cortex, and projects mainly to the cortex, thalamus, and spinal cord. The projection of reticular nuclei to spinal cord is important in control of motor activity as they profoundly affect the motor neuronal excitability, especially of the gamma motor neurons. In this regard, two reticular nuclei are important nucleus, that is reticularis pontis in pons and nucleus gigantocellularis in medulla. Accordingly, there are two main reticulospinal tract, that is pontine reticulospinal tract and medullary reticulospinal tract. Reticulospinal tract are the most important medial system pathways for control of posture. Pontine reticulospinal tract. So these tracts originate from the nuclei reticularis pontis oralis and nucleus reticularis pontis caudalis located in the pontine reticular formation. These tracts descend down ipsilaterally in the medial funiculus in the spinal cord. The fibers terminate on the medial group of interneurons and motor neurons that innervate the proximal and axial group of the muscles of the body. Their function is similar to that of lateral vestibulospinal tract. It excites the motor neurons of proximal extensor muscles that are involved in the regulation of posture. Medullary reticulospinal tracts. These originate from the nucleus gigantocellularis located in the reticular formation, and these tracts descends down ipsilaterally in the ventral funiculus of the spinal cord and terminate on the medial group of interneurons and motor neurons that innervate the proximal group of muscles. Their function is mainly inhibitory, that they inhibits the activity of the motor neuron that innervate the extensor neurons. Coming to the tectospinal tract, these originates from the tectum or the superior colliculus, that is the deeper layers. They immediately after originating from the superior colliculus cross over to the opposite side below the periaqueductal gray. The fibers then descend down in the ventral funiculus of the spinal cord to terminate on the medial group of interneurons and motor neurons. This is the smallest of all descending tracts as it extends up to mid-cervical region of the spinal cord. Note all the medial descending pathways descend down ipsilaterally in the brain and spinal cord except tectospinal that crosses over the opposite side. Their function is mainly, that is the superior colliculus mainly receives visual inputs, therefore tectospinal tract regulates the contralateral movement of the head in response to visual stimuli. Other descending pathways like monoaminergic pathways, these include raphe-spinal or cerulospinal pathways. Raphe-spinal tract, they originates from the nucleus raphe magnus in the medulla, and these fibers descend down ipsilaterally and terminate on the interneurons on the dorsal horn that inhibits the transmission of impulses in the nociceptive pathway. Few fibers also terminate on the interneurons in the ventral horn that are excitatory to motor neurons. These fibers of raphe-spinal nucleus pathway are serotonergic and they inhibit the nociceptive transmission in the spinal cord, that is, they are involved in the endogenous pain inhibiting system. Though their transmission on the motor neurons, they are involved in sensory motor coordination at the level of spinal cord. Cerulospinal tract. These fibers originate from the nucleus locus ceruleus and nucleus subceruleus. The fibers mainly descend down ipsilaterally in the spinal cord to terminate on the interneurons and motor neurons. The function of these fibers, that these pathway contains norepinephrine and the pathway is inhibitory to the nociceptive afferents and also to the motor neurons. It alters the excitability of the motor neurons to different stimuli and brings sensory motor coordination in the spinal cord. So this is the different tracts, different extrapyramidal tracts showing their influence. The rubrospinal tract and tectospinal tracts, they are going to mainly affect the alpha motor neuron activity on the opposite side, whereas The reticulospinal tract, the pontine and medullary. So pontine, they're mainly facilitatory to the gamma motor neuron activity on the both the side, whereas uh, the medullary reticular formation, they are inhibitory on the both side, whereas the vestibular spinal tract, they are going to affect the alpha motor neuron activity ipsilaterally. And all these subcortical nuclei, they will be affected. They will be influenced from the cortex, that is basal ganglia, caudate nucleus, and putamen, and cerebellum. Coming to lower motor neuron paralysis. Lower motor neuron paralysis occurs in the diseases that cause destruction of the anterior horn cells or their axons in the dorsal root, nerve plexuses, or in the peripheral nerves. The examples of lower motor neuron diseases are nerve lesion as occurs in the nerve injury or diseases of the nerve, poliomyelitis, motor neuron disease, and lesion of nerve roots. The features of lower motor paralysis are: there will be a flaccid paralysis, that is, muscles become hypotonic. There will be pronounced muscle atrophy. The individual muscles are affected depending on the muscles supplied by that particular nerve. The tendon reflexes are diminished or they're absent. Superficial reflexes are lost. There will be flexor plantar response, that is, Babinski's sign is not elicited, unlike upper motor neuron lesion. Involuntary movements like fascicular twitches are observed. Denervation potential like fibrillation, fasciculation, and sharp waves are seen in electromyogram, and the nerve conduction is decreased or sometimes it is absent. So these are some of the difference between upper motor neuron and lower motor neuron paralysis. In upper motor neuron paralysis, uh, the group of muscles are involved, whereas in lower motor, the individual muscles are affected. There will be no atrophy in upper motor neuron, but there will be atrophy. Atrophy will be pronounced in lower motor neuron. There will be spastic paralysis is seen in upper motor neuron lesion, where flaccid paralysis, that is hypotonia, is seen in lower motor. Tendon reflexes are exaggerated in upper motor neuron lesion, diminished or absent in lower motor neuron lesion. Superficial reflexes are absent in both upper motor as well as lower motor neuron lesion. In lower motor neuron, in upper motor neuron lesion, the the, the superficial reflexes are absent because these reflexes are integrated at the level of the cortex. And Babinski sign, there will be extensor plantar response in upper motor neuron and flexor response in lower motor neuron. Involuntary movements are absent in upper motor neuron. Sometimes there can be present in the form of fascicular twitches. The electromyogram EMG changes, there will be no denervation potential, whereas denervation potentials is seen in lower motor neuron paralysis. Nerve conduction study will be normal in upper motor neuron lesion. There will be reduced nerve conduction in lower motor neuron lesion as the nerves are affected. Physiological basis for these symptoms: as the lower motor neurons are interrupted, the innervation to the muscle is lost, therefore pronounced muscle atrophy occurs as secretion of nerve growth factors is abolished and muscle function is lost. The muscles that are innervated by the nerve are only affected and not the muscles of one limb or side of the body as seen in upper motor neuron paralysis. Loss of motor neuron disrupt the reflex arc of the stretch reflexes as well as superficial reflexes. Therefore, both tendon and superficial reflexes are diminished or lost in lower motor neuron paralysis. The denervation abolishes the influence on alpha motor neurons that results in hypotonia and an important feature of lower motor neuron paralysis. Usually muscular paralysis is associated with sensory changes because the nerve that carries the motor impulses from the spinal cord also transmits sensory information to the spinal cord. The nerve conduction is decreased because of the damage to the nerve fibers. Babinski sign is not elicited due to the loss of motor neuron activity, but if at all present, is of normal flexor type. As the muscle is denervated, the denervation potential are observed in the EMG in the form of fibrillation or fascicular twitches. The pattern of paralysis uh, or Paraplegia means complete loss of voluntary movement, whereas paresis refers to the weakness of the muscles, that is, incomplete paralysis. Depending on the distribution of the parts of the body involved, paralysis is divided into the following categories. The monoplegia refers to the weakness or paralysis of uh, all the muscles of one limb, that is leg or arm. Paralysis of individual muscle or group of muscle is not monoplegia. Examples of monoplegia are crural monoplegia that occurs due to the trauma, myelitis, disc prolapse or tumor of the thoracolumbar segments of the spinal cord, or brachial monoplegia that occurs due to the disease affecting the cervical segments. Monoplegia may also occur due to the central cortical defect, that is the thromboembotic phenomenon or infarction, or circumscribed tumor or abscess at the cortex. Hemiplegia means paralysis of one half the body. This is commonest form of paralysis that involves arm, leg, and sometimes face on the one side of the body. Usually it occurs due to the lesion of the corticospinal pathway at the internal capsule that results in contralateral hemiplegia. Paraplegia refers to the paralysis of both lower limbs. It usually occurs due to the spinal cord injury or diseases that transects the cord. Rarely the disease of motor cortex, cauda equina, or peripheral nerve causes paraplegia. Quadriplegia or tetraplegia indicates paralysis of all four extremities. It usually occurs due to the transection of spinal cord in the upper cervical segments. The diseases of the upper motor neuron bilaterally in the cervical cord, brainstem, or cerebellum can also cause quadriplegia. Diplegia is a special form of quadriplegia which the legs are affected more than the arms. Triplegia occurs most often as a transitional condition in the development or partial recovery from tetraplegia. Isolated paralysis of one or more muscle groups occur due to the disease of particular nerve or the branch of the nerve. This is in brief about the extrapyramidal tracts, the difference between upper motor neuron lesion and the characteristics of lower motor neuron lesion. Thank you.